Hello, everyone. It is with great pleasure I welcome all of you for this curtain raiser webinar of DTech 2024. As you know, that the conference is just around the corner, and from 17th to 19th May, all of us will be in Kochi, and we will be having 3 days of scientific feast there on diabetes technology and advances in therapeutics. Today, we have a very special guest with us, Dr. Tade Batiliru, who happens to be the patron of DTech. And this year we will miss his presence in person at Kochi. But we are honored to have you, sir, for this curtain raiser now. And along with me, I have Dr. Jyoti Dev, who is the president of Diabetes Technology Trust of India, Dr. Bansi Sabu, the founder of Dtech, Dr. Mithun Bhartiya, my very good friend, and Dr. Manoj Chawla and Dr. Rakesh Parikh. We are here for this very important topic, that is the use of CGM in type 2 diabetes. So before we go live, I would like to hand over the proceedings to Dr. Jyoti Dev, so that he can welcome Dr. Tade Batiliru, and then we can proceed with the webinar.
Thank you, Amit, for this welcome address. And I have great pleasure in welcoming Dr. Tade Batiliru, our good friend. And he is the inspiration for Dtech. And he has been the co-organizer and co-founder of ATTD. And he is currently the professor and head of Department of Endocrinology at the University Medical Center, Ljubljana. And he has completed his clinical fellowship at Loyola University of Chicago, USA. He's a globetrotter, and he just returned from Italy. And last week, he was at Orlando in the United States. He has received several medals, including the gold medal for research at the University of Ljubljana in 2017. And he serves in the editorial board of multiple journals, including Diabetes Care, the official journal of American Diabetes Association, Journal of Pediatric Endocrinology and Metabolism, and so on. And he has evolved as the biggest global diabetes technology convention inventor, and he is a global key opinion leader. And he has also co-authored over 322 papers in international peer-reviewed journals and contributed chapters to several international books. And we are highly privileged as the officials from the Diabetes Technology Trust of India, and all our friends are here, Dr. Bansi Sabu, Dr. Manoj Chawla, Dr. Amit Gupta, Dr. Rakesh Parikh, Dr. Mithun Bhartiya, and on behalf of Diabetes Technology Trust of India, over to Dr. Tade Batiliru. Please.
Thank you very much, dear friends. I shared my screen. Can you see it?
Your screen was visible, but not now visible. Can you share it once again?
You need to reshare.
Yeah.
So I will share it again.
Yeah.
Not yet, Professor Tade.
Don't worry.
Yes, it is.
Yeah.
Perfect.
Yeah, perfect.
Okay. So, dear friends, dear colleagues, thank you very much for inviting me. It's an honor. I'm really sorry I won't be with you in person next week, but I'm very pleased to be able to say hello to you all and wish you all my best from Europe. Those are my disclosures for you to review. And I will focus on type 2 diabetes, but I will also mention non-insulin treated type 2 diabetes, because I believe this is important. So a little bit of a background, and then the evidence that we have. And perhaps we will discuss this time in range and time in tight range. What is the new opportunity perhaps for all of us? So background. So I like this paper that's coming from the United Kingdom. It's a biobank, and this is 1/3 people included, and none of them had diabetes. And when they calculated their glycemia on the lower normal edge as compared to the upper normal edge, as you can see, the risk of cardiovascular is already 3 times increased. So a 3-time increase of the cardiovascular. And this, of course, is major because this is people without diabetes, with glucose within the normal range. So a very important message. And the same study then checked cardiovascular risk here in this Journal of American College of Cardiology publications in the entire spectrum. As you can see, 2,500 to 250,000 people that have normal glycemia, 64,000 with pre-diabetes, and 12,000 with type 2 diabetes. And please note that the risk linearly increased. So the higher the glucose, the higher the cardiovascular risk. And of course, when you look into the numbers in pre-diabetes already, the risk is 2 times increased. So you have a spectrum for low normal to upper normal 3 times, and in pre-diabetes, another 2 times increase in the risk of diabetes. Here you have a graphical representation. A1C is used. As you can see, the higher the A1C, the higher the risk. And please note here, even with an A1C of 6.6, which is by many considered an acceptable value, we have this red line here of the increased cardiovascular risk. It is a 3 to 4 times gradient in between 5 and 7% of A1C. What I'm more interested in cardiovascular, to be honest with you, is the brain. Because with cardiovascular, okay, you have a heart attack, but with the brain, you have dementia. And you don't even remember yourself. You don't remember your relatives. A very serious disorder. And here we have data that the cognitive impairment in type 2 diabetes is widely present and increasing with high glucose. Please note that the visuospatial function is the most severely and the first affected, similarly to type 1 diabetes. This is the Swedish National Registry. And please note, the Swedish National Registry, they have, again, more than 1/3 people with type 2, and the control group is 1.8 million people. So it's a very considerable study. And what they showed is that vascular dementia and non-vascular dementia is associated with diabetes. And also that the higher the mean glucose, the more the risk is increased. So again, glucose is dangerous to the brain. But this interesting study from the United States, the ARIC study, demonstrated that if you have the initiation of diabetes early, before 60 years, and many nowadays have diabetes before 60 years, as you can see, you have a 3-fold increase for the risk of dementia in this population. And this is people with mild cognitive impairment in the United States. And when they checked for diabetes, they showed that even when all covariates were actually adjusted for socio-demographic, behavioral, medical conditions, physical function, and diabetes treatment, it was highly significant. And please note, it was already there in pre-diabetes. So very early beginning of this mild cognitive impairment. And finally, the Maastricht study published in neuroimaging. So 3,000 normal glucose, pre-diabetes, 809, almost 900 with diabetes, with a very good control of 6.7 A1C here. Please note that there were actually both associated with fasting glucose and with 2 hours post OGTT glucose demonstrated damage into the subcortical gray matter. This is interesting, and this is repeated continuously. So this is a very recent publication when they show severe cerebral white matter lesions associated with glycemia. This is a Japanese study in type 2 diabetes. So they actually show the time in range was the most accurate marker to follow this white matter lesions, but also time above range and the hypercomponent. To the contrary, this was not associated with variability or low glucose. And this is a very important message. This is the high glucose that damages the brain, not the low glucose. So white matter lesions in this study were associated with indices of high glucose. And this study comes from Korea and is super interesting because this is radiologists, not diabetologists. And they ask the question whether they can detect type 2 diabetes based on the scan of the brain. And they were able to show this, that they can actually tell this person has diabetes based on the basal ganglia, so subcortical gray matter atrophy, and consequently on the white matter lesions. So what they proposed as a theory is that high glucose, hyperglycemia, starts with these small vessels that are nurturing the subcortical gray matter, and then consequently we have a axonal loss. We have a white matter damage. So please remember the first message: elevated glucose is harmful, also in pre-diabetes and also in people without diabetes, which is a very important message. Second is that we know from the UK PDS that the early we start therapy, the better is the long-term outcome. This is death from any cause, myocardial infarction. But of course, the UK PDS is 35 years old. We also have new data here. So this is a large cohort trial, diabetes and aging study. Please note exactly the same microvascular events and macrovascular events. The sooner you start the intervention, the better is the long-term outcome. So we have no time to lose. This is the second message. After we know that glucose is dangerous, we have to act immediately with disease-modifying elements. So that's why we proposed in this kind of an overview that we really have to act more swiftly, faster than we used to in the last 30 years. And that it also is time to switch from this average of glucose that is expressed by A1C to the more manageable and more understandable time in range. Do we have evidence? So the best evidence in type 2, particularly in basal only, I will only focus on those because MDI is so many papers, nobody needs to be persuaded. But this is basal only therapy, and this is a beautiful study, JAMA led by Rich Bergenstahl, the mobile study. And please note, there is a clear effect of CGM on basal only. And then the HypoH study here demonstrating that the time in range, of course, was improved in complex and non-complex people. And interestingly, what they showed, I will show you here on this graph, is that cognitive impairment was associated with high diurnal time above range. These people also had actually time below range increase, but still within the target. So it is the time above range that also in this study showed damage to the cognitive development. Importantly, A1C was useless in this study and not associated with any either hypoglycemia or any other clinical parameters. So we should really focus on time in range. And this study, that's also new, so it's online in April this year and comes from the Steno Diabetes Center. This is actually a type 2 diabetes on insulin. Again, so 83% basal only, 66% on a GLP-1 receptor analog, and they still had some C-peptide present. Please note what the CGM did. So this is a well-treated population from Denmark, having GLP-1 receptor agonists, having basal insulin. As soon as you introduce CGM, the time in range goes up and the time above range go down without any cost to low glucose. Additionally, they also lost some weight because CGM is also a behavioral tool. So very, very important outcomes in this randomized controlled trial from the Steno Center in Denmark. And this is an interesting study also because it shows non-insulin treated separately. So non-insulin treated, please note here, they have initial time in range only 52, that this goes up to 72, so 20% increase of time in range. And all this because they reduced time above range. So a very important outcome. Finally, you have this intervention study from Korea when there was no medications. So only CGM and diet with a very simple philosophy. So if the healthy food was recorded and if the CGM was okay, do nothing. If the food was wrong, change the food. If the glucose was high, change the food again and make sure your postprandial is right. Please note that the A1C went down very considerably in this study just with this intervention. And what is important, not only the A1C, but the fasting glucose and the body weight went down. So exactly what we wanted. And please note that the only intervention was this algorithm with CGM and with the change in diet when necessary. Also, of course, with the reduction of weight and A1C, blood pressure decreased. And this is the immediate study. Also interesting, they demonstrate a 10% increase in time in range. And importantly also, that most of this increase was within tight range, which means that the variability also reduced at the same time. So a very important result. And 10% in time in range, but 8.5%. So the majority of this was in tight range. And this, of course, is a very important message. Another, the benefit of CGM that we may discuss. At the same time, all the prompts were significantly in favor. So basically, better monitoring satisfaction and no additional burden, which again is an important message from a study. This is healthy adults and people with type 2 diabetes. This is an analysis, a retrospective analysis, a very short usage of CGM, not a very big study, as you can see. But again, just the use of CGM showed an improvement, of course, in this, both in healthy and pre-diabetes, as well as those with diabetes. They did not report on time in tight range. And this study is an intervention study, actually an observational retrospective study from the Canadian private payer claims. And please note that here the outcome was the treatment progression. So how well was these individuals treated? And they report a 2 to 3 times higher progression. Please note that the use of CGM in non-insulin or insulin treated, the difference. So the always without CGM is the dashed line, and with CGM is the full line. So always the full line is considerably higher, which means that perhaps 100 or more than 100% faster they went to a more relevant therapy and were able to control glycemia better. So higher increase in progression, also in those that had more experience with CGM. Finally, let's focus on meta-analysis. So this is the one that comes mostly from UK, published in Diabetes Care earlier this year. Please note CGM versus SMBG, a clear meta-analysis, significant benefit demonstrated. Here, this is intermittently scanned CGM, a clear advantage, as you can see in red. And of course, it's also an impact of the body composition that they couldn't assess exactly because so few studies reported, but I showed you several actually demonstrate a decrease in body weight, which is a really, if you want, very welcome additional effect of this use. And the next one published in JCM in March of this year, 2 months ago, this is CGM and intermittently scanned CGM. And they both show a very clear benefit. So a mean decrease of A1C 0.3% only when this intervention. Obviously, time in range went up and time below range went down. So they also report in this meta-analysis on the time in range. And this is a specific paper on non-insulin treated. I think a very good contribution to our evidence. And this is published a month ago in DTT. Here you have A1C level and time in range. As you can see, also in non-insulin treated, the same. An improvement of A1C minus 0.3% and a time in range of almost 9%. So a really important outcome here in both, very significant, of course, in both occasions. Importantly, all this was done with the reducing of the high glucose. This is the most important message. And at the same time, also hypoglycemia below 54 was significantly reduced. So I think all the good news that you can get from a meta-analysis as a cherry on the top of this is that also participant satisfaction actually significantly improved. This is a recent meta-analysis published in Diabetologia that has a little bit of a different angle. So here they showed A1C, they showed separately, which is very significant, and exactly the same 0.3% reduction. And they also show the non-insulin separately, which I think is of particular importance. Please note the same 0.3% reduction in A1C. So a very, very important message, very new, very fresh, that we all should actually learn from. And here you have time in range, time below range, time above range, all significantly improved. A concomitant increase in time in range and at the same time decrease of hypoglycemia. So significant and clinically meaningful. The question sometimes is whether older adults also can benefit. And this is a beautiful paper from Diabetes Care saying that older adults particularly benefit from the technology. And I like this statement coming from this very, very prominent group from the United States, diabetologists, saying CGM should be made readily available to all individuals with diabetes. Payers and policymakers have to catch up to understand this message, and researchers need to catch up. So we have to catch up to demonstrate, to bring enough data to increase the accessibility to all people with diabetes. I was privileged to also participate in a paper published in the Journal of Indian Association of Physicians last year. And here we propose intermittent use of CGM in type 2 diabetes, particularly in non-insulin treated type 2 diabetes, because in the restricted access areas, this intermittent strategy can reduce costs to these people that cannot afford it. And of course, it's a very intelligent approach to at least give a limited feedback and start somewhere to improve the situation with diabetes. But at the same time, of course, we have to make our best to improve the access for all people with diabetes in the world. I would like to touch a little bit the gestational diabetes, just to show you the gestational diabetes is a very important area where CGM, of course, is helpful. Please note, all important outcomes were improved. We are not surprised, of course. So just another very important part that we need to increase access to these ladies that have gestational diabetes. Perhaps finally, this very recent online publication in Diabetologia in the ICU demonstrating that time in range that is below the threshold of 180 actually significantly improves mortality in this ICU. This is a report from China, but a very interesting one. And I think an important message that we also have to include into our knowledge and make sure it is used in our ICUs. This is at risk for type 2 diabetes, a publication online published 2 months ago, a very interesting, as you can see, randomized trial with a control group. So either the standard of care for people with the risk of type 2, so pre-diabetes, and CGM. And please note they had a nice app. The study comes from Japan. They have these very nice apps that they used. And this is the difference here in change in BMI. As you can see, a very significant difference. And the time in tight range improved. They specifically report time in tight range. So a very important outcome with people with pre-diabetes, improved time in tight range, which means near normal glycemia, and a concomitant reduction in weight, of course, because they get this feedback. I believe that this will be likely helped by artificial intelligence. We are waiting for this to happen, that these CGM devices will have artificial intelligence that will analyze the data automatically and give a clear advice to the physician, and finally, at some point, also to the person with diabetes. This is the Endo Digital that is used in the United States and already have the FDA and the CE mark. And this part can be embedded in the Epic system that they use widely in the United States. There are some potential disadvantages of CGM, of course, and the most prominent one is skin reactions. as you can see, approximately of a 25, so 1/4 of people have skin reactions to this. But the message is that very few discontinue the use, only 3% approximately. So despite the fact, this is a recent publication a month ago in DTT, a large analysis showing that despite the fact that perhaps in between 25 and 30% have skin reactions to these sensors, they still do not discontinue. Only 3.2% discontinued CGM in this study. And of course, the second thing actually is the disparity. So the disparity is a terrible trouble. Here the study shows that even people from all different social subgroups, they benefit exactly the same. So it's not that people with disadvantages cannot use it. It is simply they don't get it. If they get it, they get the same positive outcome as anybody else. So the fight to make CGM available to everybody, also to those that are in difficulties financially or socially, is very important. Finally, the question what people with diabetes think about CGM. As you can see here in this survey of the Time in Range Coalition, type 2 diabetes on insulin, type 2 diabetes without insulin, time in range for them is the first most important thing. And this is a meta-analysis of the hypoglycemia fear survey. And as you can see, all are very significantly in favor, of course, of the use of CGM. Is it cost effective? Well, I will only share with you some European data. This is the French. The French have a very good national database. So you can here compare the clinical part with the CGM part. If you put the two databases together, this is 74,000 individuals. Please note a decrease of acute events of 50% in type 1 and of 40% in type 2 diabetes the first year. This is the second year study, 50-50 decrease, which means a lot of money is saved immediately as soon as you start CGM. And here is the attrition rate. And as you can see here, also after 2 years, most people, 85% still use actually 88%, I should say, still use CGM in France. So a very good outcome. This is people with basal-only therapy, exactly the same outcome, 60% in this reduction, and a faster intensification of therapy, same as in Canada. And this is the older population, and again, exactly the same. They're very successful with CGM, and it is a 30 to 40% first and second year decrease in acute events. Also in this population that's more fragile, so less acute events, of course, is even more important. Attrition rate in this group, 90% still use the sensor after 2 years. So this elderly population looks like seems to be even the most successful. And this is it's just another view. So this is non-intensive diabetes therapy, because I told you I'm interested in this non-insulin treated. This is a insurance data from Canada. And please look. So if you look at acute events before CGM and after CGM, this is acute events all together, and this is all-cause hospitalization. Both of them are reduced when you use CGM. So immediate saving of the money when you start CGM. A little bit on the management philosophy. So please know this is one of the first reports. This comes from Japan, demonstrating, so this is people with normal albuminuria, microalbuminuria, and macroalbuminuria that have a very comparable BMI that is very low. Please note, because this is typical for the Japanese population and maybe also relevant for the Indian population. So diabetes starts very early with the much lower BMI that we see in Europe. This is the A1C. Please note, I mean, the A1C is not terribly high, and these people still have micro and macroalbuminuria. And time in range is in target, as is, of course, A1C. So this population, as you can see here, if you look, the models that corrected for the comorbidity, A1C was useless. Please note, there is no significant difference in A1C between normal albuminuria or macroalbuminuria. GMI, so the calculated A1C is already significant. So is time in range, which is very important. So is time in tight range. So please note, so the time in range retains significant predictive role, whereas A1C after adjustments actually is useless. Just another really important message that we should use time in range to identify people at risk, let's say in this case for kidney disease. How's about time in tight range? Just to show you, this is one study with a dual GLP-GIP agonist. And of course, at the end of the study, time in range was 91%. So it looks like we do need a more stringent target. And here is the more stringent target. This is time in tight range. It was still 73%. So it looks like that if you use a very potent therapy in early stage diabetes, time in tight range can be achieved. And of course, maybe the most important outcome. And this is an interesting study because in this population, in the Maastricht study, time in range was in between 94 and 100%. So almost everybody was above 90%. And please note here, despite this fact, it was still a relation between the carotid femoral pulse velocity, which is a proxy of cardiovascular disease, and time in range. Despite the fact it was all above 90%. So here, again, a time in tight range would be a better outcome. The last is the devotee recalculation from Rich Bergenstahl. Please note, there is no association with MACE, severe hypoglycemic, or microvascular with A1C. But there is a significant correlation with derived time in range for MACE, for severe hypoglycemia, and for microvascular events. And when you look, the 70% cutoff seems nice, but here it flattens up. So here we need perhaps a better marker, which could be time in tight range. Just to show you, this is drug-naive Japanese patients, time in tight range. Please note how important it is. The more they go toward the diabetes, this is a very recent publication, online mid-March, the more they go into diabetes, the more time in tight range they lose. So time in tight range is really a parameter here. Please note, a difference becomes 1.8 times and then 1.2 times because the loss, the delta, the largest delta is in time in tight range. This is the first thing that these people lose. So most initial loss of time in range goes to the time in tight range in population that is drug naive and is going towards type 2 diabetes. In our consensus for the studies, we were lucky because we did include time in tight range, and also the regulatory agencies now really want it. What's the perspective? We just published in Nature Review a paper with a group of colleagues that's saying basically that CGM should be available to everybody with diabetes. This is the most important message. We also discussed, like in the paper with the Indian colleagues, an intermittent use every 3 months for the environments when at the moment that CGM is less readily accessible. And we also give some initial summary of the evidence that actually can support what we are saying. And we are also saying what else needs to be done, actually, particularly so really using time in range and, of course, electronic medical records, if available, with the artificial intelligence would be helpful. And this is perhaps an integrated, personalized care that we hope can be available to more and more people with diabetes. Allow me to propose a couple of conclusions to you. The first conclusion, hyperglycemia, high glucose is dangerous. CGM help all individuals with diabetes, regardless of the therapy. And perhaps time in tight range is a new target for optimal control, maybe even remission at some point. So it actually is perhaps a good idea to those that are very successful and have access to very modern medicines and technology. Warmly invited to Amsterdam. The next meeting will be in March 19 to 22nd next year. We will have a lot of new trials and new data on modern medications, particularly, of course, potent triple agonists, and of course on technology. With this, I thank you very much for being with me, for your kind invitation, and my very best wishes. This is my team. They have to work while I speak. Thank you very much.
Thank you, Dr. Tare. That was an excellent, and I'm sure people who have logged in have learned a lot from you and with the new evidence. I think before we take any questions, we would like, a DTech 2024 video to be played. So Alex, if you could just play the video for us. Thank you, Alex Evans. Dr. Tare, we have a few questions from the audience for you. Some of them may be simple, but it's the best time to ask the master simple questions. It's always nice to take his perspective. So we have a question, in a country like India where resources can be widely varied. And if patients also have different perspectives, ideas when they come and suddenly they see the CGMS. If somebody who's used to a SMBG and says, well, I'm ready to do SMBG 5 to 6 times a day in a cost-constrained India versus CGMS, your take on that patient?
Well, I think we discussed this several times also with many colleagues that are Indian by origin and work outside India. And I think in a way we have to help the Indian government to understand that it should support people that can afford CGM, because finally it's important for the entire society. The amount of people with diabetes in India is just immense, and it's going up. And since we know that CGM has a potential to change behavioral part, it's an important investment from the society. So my reply to this is I'm not I try to live realistically. So I do not think that everybody will be rich enough to buy it. There is no way. But to those that cannot, society, I think, should help. So perhaps the next step is in India to persuade the government that this is an important behavioral tool that can help change the way people eat and behave, and change the attitude toward glycemia. And this, of course, is important for the entire society, because at the end, it will reduce the costs that society have with these people. So this perhaps is an idea that we all should follow. And I also promised to Professor Kamlesh Kunti and Professor Partakar to help, if necessary, to persuade the government to do something.
Thank you. We have got 2 kinds of CGMS that's available, Dr. Tare. One was the blinded CGMS, which Abbott is kind of somehow a little less interested. They cost around $25. The real-time CGMS is $50. In a T2DM patient, can one start with the blinded and then refine that to a real-time, or start from a real-time and then refine to a blinded one?
blinded is actually, of course, if this is all you have, you use it. It's better than nothing, but it is history, basically. So I don't know. I didn't know it was less expensive. It wasn't less expensive in our environment. So in our environment, it has gone away completely. It doesn't exist anymore. So I think perhaps the best thing would be that we get more competition on the market. And this is happening. So, of course, we want high quality. We want the best. We don't want things that just have the name CGM and don't work. And unfortunately, we do get those devices to Europe that get this easy CE mark from I don't know where. But then we use it and we see it doesn't work really because it's not accurate. So this is a danger. But on the other hand, new devices are coming that are accurate and that get the FDA approval. And this, of course, is interesting because I hope the price should go down also a little bit. And I know that nobody is enthusiastic about lowering the price, but at some point, this will happen because it also happened with SMBG and all other devices. And, my also suggestion is India is the country with the highest development and, new ideas and technology. So perhaps we need an Indian CGM that could help millions of people. So perhaps you find a local producer that can invent, a thing that would be more accessible. But should, of course, be accurate and should, of course, meet all the standards that we need so that the people are safe.
And Dr. Tari, a lot of people get confused with the concept of MARD when it comes to CGM. Do you want to tell them what to ask if a new CGM comes down, a new rep comes with a CGMS, flashing? What are the 2 questions they can ask to know whether, that's the reliability of that CGMS?
The most important is that the MART takes all the data in, because what they do is, unfortunately, particularly we had recently a Chinese company, they take high glucose SMART, medium glucose SMART, low glucose SMART, and all looks perfect. But they take out the transitions from normal glycemia to high. And because during the transition, we know there is the biggest difference, his SMARTs are artificially low. If you take all the data in, so including the transition, then of course the MART is the MART. And of course also what's the comparator, if the comparator is a high standard FDA approved device or not. So these 2 questions are the most important. So MART should take all data in, entire 14, 2 weeks or 10 days, whatever you like, entire 10 days of the data of the sensor. Then it's the real MART. If not, it's basically cheating.
Manoj, you can ask the question. Manoj is asking.
Manoj, you want to
Okay. Sure. Professor Tare, always a pleasure, and thank you so much for joining us this evening.
Connectivity is poor. Can you keep your video?
Mano, I don't hear you.
Manoj, you put your video off. Maybe the bandwidth is a little off.
Or you can just put in the chat box.
2 questions. What specific population would you assignment tight range, specifically for which population? Sensors which are genuine real time, would we still call them as flash, as we really don't have to flash it anymore?
Yeah, thank you for these 2 questions. So I'll start with the second one. Flash is history. Flash is history. So we now use, real time. Every flash is becoming real time. If not really, then people hack it anyway. So I think we should forget about this division. It's CGM and that's it. The second question, I think that people that can reach very easily high time in range. So time in range way above 70%, these people may benefit from time in tight range. So this is particularly people that can afford modern medications, particularly GLP-1 receptor agonists, and are early enough and they are not a danger of hypoglycemia. So then, of course, we can, suggest to them that they go even, to a more stringent target. But it shouldn't be a threat to people. It should be a suggestion, an opportunity. So if they like, they have another opportunity now to see even more benefits and to protect themselves from high glucose even better.
Amit had a question.
So sorry, one second, Mithun, just as an extension. Professor Tade, so would you say those who are really vying for remission by all particular means should be looking at time and tide?
Remission is a controversial thing at least in Europe, because what they want is, they say remission is only if you are without any therapy. I very much disagree with this. Very much disagree, because if you ask the cancer people, they have maintenance therapy and they still speak about remission. So I don't know why diabetology is different here. So to me, remission is if you have time in tight range above 90%. That's remission of diabetes, because you go back to pre-diabetes. This is remission. And in my view, it doesn't mean that you quit all therapy, because it doesn't make any sense, because then they can also say, okay, so you can also stop your behavioral change. If you stop your behavioral change, you will get diabetes back. It's nonsense. So the minimum you have to keep is your behavioral change, if not medication. So I think it's confused. I think the remission is if your time in tight range is more than 90%. We are not in agreement. This is just my suggestion, unfortunately. But I hope at some point this can be accepted and people can say, look, I mean, with medications, in my change with lifestyle, I am without diabetes. And this, of course, is a good news.
Just for the audience, Dr. Tade is a pediatric endocrinologist taking care of all type 1. And his comment on reversal of diabetes and remission of diabetes, I mean, you can listen that. It's a great thought, what he's talking about, the remission. I mean, we really loved it. Tade, one more thing that, for pre-diabetes, as you are saying for CGM, how long they should use it? CGM then continuously, because for their behavior change. And that's the reason we have used one, me, Jyoti, Anup Mishra, and many of you along with us, and how frequently they can use the intermittent. But there is no international guideline for the people with type 2 diabetes, non-insulin users, or the pre-diabetic population. Can they use it intermittently instead of continuous glucose monitoring?
I think, we actually need to put these guidelines together. There is very hard to get a consensus on, because some people are very conservative. But there is a fact that more and more people with pre-diabetes will use CGM, and they are very motivated. This is perhaps a surprise to many, because they say, okay, if I get CGM, if I see my glycemia, I can prevent going to diabetes and injections. So they're highly motivated to change their lifestyle. And there are more and more studies, 3 published and several ongoing, that basically want to prove it. So, even if we resist, people will use CGM in pre-diabetes, will change their lifestyle with it, and hopefully they will prevent going into diabetes. I think this is the real goal with CGM in pre-diabetes. It is preventing the development of diabetes. And the only way to do so is to tell them, look, keep your time in tight range above 90% with whatever you do.
So why is not in the guideline in T2 diabetes management? I'm not talking about
because there are people, that want to be in control. There are these very important diabetologists in Europe that believe that they should decide on everything, and they will tell you there is no data. There is no data to support insulin use either, and everybody is using it.
Sir, I wanted to ask one thing. That the use of CGM, it all started with type 1 diabetes. Gradually, as you already said, that type doesn't matter, and anyone with diabetes is going to benefit the use of CGM. So my question is to you is that even with pre-diabetes, people are using, and it is a great behavioral change tool. So how do you see the use of CGM in people without diabetes or pre-diabetes or any kind of dysglycemia, but with obesity?
I think it's a natural way. I mean, if they can afford it, at least here in obesity, I believe that intermittent use makes sense, right? Because first you want to know whether you are hyperglycemic. Many are. If they are, they go to a different group. If they are really not, like in Europe, you can have obese people without dysglycemia. Then this is not their risk at the moment. So they can, do something and repeat it perhaps in a year to see whether they were successful. So obesity is a really important group because you can separate people at higher risk, being intermittently dysglycemic, from people that do not have this higher risk. So it's a very important tool, but here very likely intermittent use will be the way to go, at least for many years.
Just an extension to that, sir. Will that help in weight loss and behavior modification in this subset of people?
I mean, behavioral modification, as soon as you are dysglycemic, is obvious. I mean, 2 randomized controlled trials have already demonstrated this. And I believe it. I mean, you don't want to have high glucose with all the evidence that we have now. You don't want to be demented. You don't want to get cardiovascular risk. Why? I mean, you're taking statins to keep your cholesterol down, and you keep CGM to keep your glucose down. And if needed, okay, you get medications from your physician to make sure the glucose is down. I think this is the right philosophy for everybody that wants to keep cognitive function and, see his or her grandchildren.
Two obese people or for pre-diabetes, should we go for further time in tight range instead of 70 to 140? Can it be 70 to 120 only? I mean,
I'm not sure. I'm not sure because you always keep this for the general population. I don't mind if you have somebody and then, for specific reasons, you go to 120. But this is already within the normal range. So then you should say also to me, my glucose go above 120. So what do you want me to do?
I mean, for behavior modification, not for anything else. For the people who are obese or for pre-diabetes, even if they go more than...
There is always a limit. I mean, I'm not a cardiologist to say that your LDL should be 0. It doesn't exist. I mean,
But you have shown the data UK Biobank that, with the people with 4.8 and with 5.8, there was a more increasing risk of cardiovascular disease and other complications. So, I mean, keeping their HbA1c of less than 5. If you want to keep their less than 5, then you have to keep their sugar between 70 to 120. If it will go more than 120, I'm sure their HbA1c will be more than 5.5.
There is no question about it. But here, if people are normoglycemic on CGM, which means that, the time in tight range is more than 90%, then the advice is keep physical activity, because by definition, your glucose will go down. I'm not sure you need to say to everybody, because 120, then it means 7 billion people. Because 7 billion people have glucose above 120. So I think these companies with CGM will love you.
No, it is only for the discussion.
But yes, I'm not there. This is not my game. So I think we have our cutoffs. If you are within the normal range, the suggestion for the lifestyle is don't get obese and exercise regularly. And with these two, your glucose will be below 120 for sure, because we know it. So I still think that we should actually keep people that do well, we should value them. We shouldn't make them patients.
Very true.
Because then, we should value them. So they do well. They are within the normal range with glucose. Yes, if they want to do more, exercise more. And your glucose will be 100 or low because, the insulin sensitivity will be so high. And this is well proven in many studies. So I don't think we should actually, go into the healthy population. I really respect people that are able to be healthy and keep healthy. Let's focus on those, that are above those well-accepted limits and try to help them get back to the healthy population.
Dr. Tade,
Can I ask?
Dr. Tade, you are the brainchild behind a TR matrix. And I have 2 questions and only you can answer. One question is on glucose variability. The recommendation is to keep it equal to or less than 36%. So do you think that with the available evidence on dementia and many other parameters, in a selected subgroup, you should bring it below probably 20 or so? And the next question is, in the earlier publications, we were correlating an A1C of 7 to more than 70% TAR. And in practice, we never encounter such a correlation. Because when the A1C is 8, the TR is different. The TR may be more than 80%. And I remember you keeping on stressing the fact that A1C is not useful. A1C is gradually being part of history. So what is your opinion on these two parameters?
Yeah, so I agree. I mean, A1C is part of history.
Oh,
no question.
okay.
Those that are diehard users of A1C, that's fine. They will die also. So it's history. So, you know, I'm not concerned with them or with anybody that wants to keep A1C. That's fine. But basically, it will go away. The reply to it, glucose variability is mostly related to hypoglycemia. Most of the therapies nowadays do not have hypoglycemia. So by definition, if your time in range is high, or even more so, if your time in tight range is high, your variability will go to 20s. So it's done. In people that are still on MDI, of course, this is a different story. Then you have to focus on hypoglycemia because you don't want them, you know, to break their hips or, you know, suffer from severe hypoglycemia. So then, of course, the focus is either time below range or variability because they correlate 0.98, basically. So whichever you prefer. I usually take time below range because for people, it's easier to understand. So if they're on MDI, you know, and they cannot afford an advanced hybrid closed loop, they should focus on time below range. And to me, you know, particularly time below 54 should really be low. We don't want people with severe hypoglycemia. We don't want to do this. But this was not the focus of talk today. This was the focus on people on non-intensive therapy.
Thank you. Thank you. Thank you, Tade.
Yeah, Manoj.
So, quick question. Can I be heard? Sorry.
Yes, Manoj.
Hello? Yeah, okay. So my question was regarding patients that you're using CGM, Professor Tade, and who seem to be worried about the distress or who complain about discomfort and anxiety with the data coming in and diabetes distress. Do you not do the CGM, or you found ways around how to convince the patient and reduce their distress?
Look, this is a very important question because what happens is, you know, people don't want to know they have diabetes. It's normal. Until you know, you're happy. You know, what doesn't hurt, what you don't know, it doesn't hurt, right? And glucose doesn't hurt. The bad message is that then you get demented. Well, that's a problem. So as you suggested, I try to talk them around. And in most cases, it works because they're not distressed with CGM. It's nonsense. They are distressed with the fact that they have high glucose. But this is why they come to you, don't they? And this is what we treat in diabetes. We treat high glucose. We are glucose, sugar doctors. I am not ashamed to be a sugar doctor. This is what I do. And of all the risk factors, sugar is by far, it's a New England Journal paper, by far most dangerous. So we should concentrate on glucose. We shouldn't be ashamed. A cardiologist and lipids are simple. Now we have every 6 months one injection and you're fine. So they want to do this, let them do this. But we do glucose. It is much more difficult and much more important. So my suggestion is that we focus really on good glucose control, particularly on cutting the high glucose down, and we will basically preserve these people healthier.
Dr. Tade, a question about your friend Rakesh. Are there any medical conditions that may affect the data of CGM that people
I'm not sure medical conditions, you know, the interferences are nicely stated if you look at the FDA approvals, because by law, they have to report all the interferences. And this may be an issue if some people, you know, some sensors, some people use preparations. We should look into it. That's really the business of the diabetologist, right? There are conditions, particularly if you are on anticoagulant, very severe anticoagulant therapy, you can have bleeding with a sensor, of course. So there are medical conditions that, you know, you should, as a physician, you should discuss and think about it. Perhaps there are conditions that we cannot use sensor. We tried once with a very severe cancer patients of chemotherapy, and they were so platelet dependent, so they were so low with platelets that it was impossible to use in this condition. But this is why we are physicians. We are all physicians. This is why we are not, I don't know what, fortune tellers or something. We are physicians, diabetologists. So we should identify conditions that either interfere with CGM. By the way, they may interfere with SMBG as well, or medical conditions where CGM is really impossible to use. There is a beautiful study published in Advanced Renal Failure, which was a question for many times, and it looks like CGM is considerably better than A1C. We know A1C doesn't work. So those are, this is how you distinguish a good diabetologist from a not so good diabetologist. Good diabetologist will know our comorbidities and will be able to decide, what's best for this individual person with diabetes.
Thank you, Dr. Tare. I think we'll not take any more questions. As all good things, we can keep Dr. Tare on asking another 2 hours of questions, but we'll not take any more audience questions. We'll ask Dr. Bansi Sabu for the vote of thanks and to, give his
Before that, I would just like to make a comment on the lighter note. Tare sir, taking clue from our webinar, our cardiologist friends, they might think of discovering something like continuous lipid monitor and something like CLM, and they start looking at the lipid variability. So I don't know what is the future of that lipid variability. So just a thought.
But lipids are simple. We don't need it. It's one injection every 6 months. I mean, come on.
Then over. Once you give it and keep your LDL cholesterol less than 55.
Yeah.
Somebody had asked that, is it possible to use CGM for performing OZT? I mean, last
No
time,
need.
so for
No
using
need.
the undercurve for studying dysglycemia.
But Bansi, there are devices which are being worked on that section, which are going to be monitoring blood pressure and sugar. So you're going to have metabolic sensors coming in. I'm sure many of you are aware. So the future is exciting here.
No,
Very
blood
true.
pressure is a more difficult question than lipids. I agree. And yes, there are there are rings and many things. And I think this is a good idea. Biofeedback on your blood pressure is a very good idea.
Great. So now it's time to, it's almost more than 1 hour. First of all, big round of applause for Dr. Tare. It was really great to listen to him and we all enjoyed. And I'm sure all those 300 doctors who logged in from India, they listened Dr. Tare and they all will miss him in Dtechcon. This time in Dtechcon, we have more than 400 doctors who are coming and we all will miss your presence. But you are patron for our society, and definitely next year at Jaipur, we would like to have you. Once again, thank you, Dr. Tare, that within just before 1 week, I asked you for your date and you agreed. And we wanted to have 1 week before our Dtechcon, a meeting, a pre-conference symposium, or sort of a curtain raiser for our Dtechcon. And just to inform all the delegates that this year ATTD is also coming to ATTD Asia, that is in month of November. And please visit the website of ATTD and see the ATTD Asia, very exciting program. And many Asian experts will be there also in ATTD Asia. And already it is open for your abstract submission. So I'm sure many of you will be there also in ATTD Asia. Once again, thank you, Dr. Tare and complete Dtech team, particularly Dr. Amit Gupta, Dr. Jyoti, Dr. Mithun, Manoj, and Rakesh, and everyone who is here for the panel discussion, and thanking each one of you. And thank you all the delegates for this wonderful program which you are attending, and thank you for sparing your valuable time. Thank you once again, Tare, and good night from India. It's
Bye
still
bye.
a good
Bye
evening.
bye. Thank you very much.
Sir, before we conclude, just one last comment. Today, our Dr. Bansi Sabu is going to receive the prestigious International Outstanding Clinician Award at the New Orleans in ACE meeting in just a couple of hours from now. So this is a big achievement for all of us, and many, many congratulations to you.
Thank you.
Congratulations, Dr. Benchi.
Thank you. Bye-bye.
Thank you, sir. Thank you. Bye-bye.
Bye.
Good night.
Recording stopped.